So this is case 19 at the AEMT level. There's a dispatch for a Charlie response for a diabetic problem. Further information is this is an apartment setting. A 25-year-old known diabetic who takes insulin cannot be awakened by his roommate. The time of the call is 06:45 hours. As far as responder safety, the usual scene hazards, weapons, devices, trips and falls, violent bystanders, plus hypoglycemic patients like any other altered mental status patient or a patient with a decreased level of consciousness, and obviously that's two different things. Altered mental status is different than decreased level of consciousness. But in any case, those patients may behave very erratically and they may attempt to harm responders because they don't realize that the responders are there to help. As far as the pathophys on this case, insulin's needed obviously to get glucose to move into the cells from the bloodstream. The glucose molecule is unable to travel into the cell on its own. It needs insulin as an escort or a key access. Insulin's produced in the pancreas in non-type 1 diabetic patients, but in the type 1 diabetic, they have to take insulin one or more times a day or have an insulin pump because failure of their pancreas has eliminated insulin from their body. Patients who take their insulins on time and as prescribed, but they fail to eat sufficiently or prone to hypoglycemia. That's why we tend to see diabetic patients with low blood sugar, even though diabetes is an issue of high blood sugar. Hypoglycemia can produce a whole bunch of symptoms: altered mental status, decreased level of consciousness, cool, pale, clammy skin, but the best way to assess hypoglycemia is to check the blood glucose level. Many times these patients will need temporary airway control. A jaw thrust is usually sufficient. Positioning their head in the ear to sternal notch position will give them the maximum airway, the sniffing position. It is usually not a good plan to use oral or nasal airways. These patients may come around fairly shortly after administration of glucose in some form. You may need to temporarily use some positive pressure ventilation, use a bag valve mask, although we should be very cautious with that, very conservative with that. Again, most of these patients can maintain their oxygenation just fine until we can get their glucose levels reversed. Use pulse ox to drive your O2 therapy, or if you don't have a pulse ox, go with a non-rebreather mask. Again, the goal is to raise this patient's level of consciousness and eliminate the need for airway and breathing management. As far as raising their glucose levels, oral glucose can be administered to any patient that can swallow. Use the buccal route, so a pinch between the cheek and gum. If that's not going to be an option because your patient can't swallow, can't maintain their own airway, then you can go to glucagon IM. If the patient is not going to be one you can get an IV on relatively quickly. But in many of these patients, if they are in the responsive to pain or unresponsive mode, IV dextrose will be the answer. Now there's a trend toward getting away from 50% dextrose to a more diluted 10% or 25% dextrose solution, but right now D50 is the plan. Usually don't need an IO for these patients because you do have that backup option of IM glucagon or oral glucose. The issue with glucagon and oral glucose is that they just take longer to work, or that patient with liver disease, severe malnutrition, may not have enough stored glycogen, stored glucose in their liver for the glucagon to actually work. And then for many years, in many services, we've given thiamine along with glucose over concerns about producing something called Wernicke's encephalopathy in these patients that are severely malnourished. There's some debate about whether that's necessary or not. Many protocols include that. Oral glucose, it's a food. It's available over the counter. They say it has a delightful taste. It comes in cherry and lemon. I don't think it's delightful, but it certainly is cherry or lemon. They come in 15, 30, and 45 gram doses. Most of the time it's the 15 that you see. Again, it's given buccally between the cheek and gum to a patient who can swallow and maintain their airway. We don't really want the patient to swallow this stuff. We want them to let it absorb through their oral mucosa, because that's a faster route of administration. We have a quicker onset with that than if they swallow it. The onset of action, however, with oral glucose is slower than IM and definitely slower than IV. Glucagon is your IM option. Some of these patients have it at home. It usually comes where it has to be reconstituted in a vial of water in a vial of powder, or the other way we've seen it is in the syringe that has the water in the syringe. You mix it with the powder and then draw it back up. And some patients' family members have been taught to use this at home. Slower onset than IV, but a little bit quicker than oral, but again, it requires that they have sufficient stored glycogen in their liver. So your malnourished patients or your liver disease patients are not a real good option for this. D50 has been the standard for years. It comes in a great big syringe, a preloaded syringe, a 50 cc syringe. It's got 25 grams in there. And then pediatric protocols have been using the diluted preparations for a long time. As far as management, a lot of times these patients can be awakened and their blood glucose levels can be returned to a normal level, 80 to 100 or more. And at that point, a lot of them don't want to go to the hospital, and in many protocols, you're allowed to not even contact medical control to discuss it. You're allowed to, if certain criteria are met in a checklist, you're allowed to accept that refusal without any further discussion. That checklist varies by protocol, but usually it's centered around the idea that we know what this was. This was only hypoglycemia. There's no other illnesses or issues going on. Their insulin dose has not been changed. They've taken their insulin like they're supposed to. There's someone there to monitor them. They're going to eat a meal of some complex carbs, not just this major IV sugar bolus, and then they spike their blood sugar, and then in a few minutes their insulin has kicked in, and now their sugar drops and drops to even lower. They need to agree to notify their physician, probably hold off on any further insulin until they talk to their physician. There may be other conditions that apply. Different protocols will give different criteria for this, but it's fairly standard practice that these hypoglycemic, known diabetic patients can become normal glycemic and then refuse. Patient safety. We mentioned earlier responder safety, and that these patients can be erratic and violent even though they wouldn't be if they were not hypoglycemic. The other issue is particularly concentrated D50. If it extravasates, if that IV blows and you have an infiltration under the skin, it can be some very nasty skin ulcers. And here's a picture of one that came from a D50 administration where the IV wasn't patent. So you want to make sure it's a big line and a big vein that's free-flowing, no problems at all with that vein. Be very confident, and then push that D50 slowly and try to avoid this complication. Again, speaking of refusal, we think of refusal as needing to have 4 elements for it to be valid. And again, refusal has a negative connotation to it. Really what we're speaking of legally is non-consent. The patient does not want to be transported. Refusal implies that there's some sort of disagreement. In many cases, we agree with the patient that transport is not needed, but we need to make sure that 4 things are in place. They must have legal capacity. They can't be a minor or under somebody else's power of attorney. They have to be able to make their own decisions legally. They have to have mental capacity, so we wait until their blood sugar level is 80 or above in most protocols, and we check them for that they are alert, they're oriented, they're in their normal state of mind, they're able to make decisions, answer questions, discuss the issue. They have to demonstrate their understanding of risk of non-transport and the benefits of ER evaluation. Not that we have told them what these are, but that they can tell them back to us. And then again, demonstrate understanding of how or when they can access help. The refusal is for that interaction only. Once we leave their side, they're no longer in contact with them, they can change their mind and we come back. So the refusal was for that moment in time. That decision was made for just at that point and doesn't carry any impact for down the road for later that day or the next day. So hypoglycemic patients are fairly common. This is a standard situation that we see, and that's the key to case 19.